So maybe I think we'll start. Hi, and thank you for joining us tonight. I'd like to welcome you to the Leukemia and Lymphoma Society of Canada's webcast, What You Should Know About COVID-19 Vaccines and Blood Cancers. In this webcast, Dr. Sita Bella will speak about what we currently know about the efficacy and safety of COVID-19 vaccines for people with blood cancers. You'll hear about the first Canadian-wide study that's underway to guide public health policies specifically for people with blood cancers following COVID-19 vaccines and what you can do to stay safe. Let me introduce myself. My name is Leslie Ann Viney, and I am the Community Services Manager for Eastern Ontario, and I'm very excited to be the host for this online event. The presentation will last approximately 60 minutes and will include a question and answer period at the end. We asked for your questions at the time of your registration and have received a little over 100 questions. So since we're limited in time, we've grouped the questions by topic and have narrowed it down to about 12 all-encompassing questions. Therefore, we will not be taking questions live. However, at the end of the presentation, if you still require more information, we will invite you to contact the Community Services Manager in your region. We will provide you with that information on how to contact them at the end of the presentation. As well, this webcast will be recorded, therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you some of our mission and highlight some of our resources. Next slide. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. Next slide. We know the current situation presents many challenges to those affected by blood cancer and their families. The Community Services Managers are here to help. They are compassionate connectors that can help you cope with your blood cancer experience. So please don't hesitate to reach out to and contact the Community Services Manager in your area for all of your needs. On our website, bloodcancers.ca, you will find a variety of educational resources and support services. For example, you'll find free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information, as well as animated videos, webcast recordings, and podcasts. Next slide. Our peer support program is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by blood cancer and shared a similar experience. Wherever possible, the participants and volunteers are matched based on their age, gender, and diagnosis, or maybe some of the issues that are most concerning to them. Next slide. In September, we launched the pilot transportation program called 1 Mile at a Time. This program is specifically designed for those experiencing financial hardships related to the cost of transportation. It offers to those eligible a one-time per person $200 Uber gift card to access rides to and from your treatment. Please speak with your Community Services Manager to see if you are eligible. Next slide. So now it's my pleasure to introduce to you our speaker, Dr. Sita Bella. Dr. Bella graduated from Western University's Medical School. She completed an internal medicine and hematology residency at the University of Toronto and a fellowship in leukemia and allogenic bone marrow transplant fellowship at Princess Margaret Cancer Centre. In 2019, Dr. Bella joined Princess Margaret Cancer Centre as an assistant professor and a clinician in quality improvement and innovation. She is the quality lead of the autologous stem cell transplant program and is engaged and involved in the development of the CAR T-cell therapy program, particularly the long-term survivorship program. Thank you for being here, Dr. Bella.
Thank you. Well, thank you for that lovely introduction, and a big thank you to the Leukemia Lymphoma Society for presenting me with the opportunity to speak about COVID-19 and blood cancers, and to share a bit of one of the studies that we have ongoing in COVID-19 and blood cancers. And thanks for coming this afternoon so that we can all learn together about COVID-19 blood cancers. And I know there's a huge turnout, so thank you for all of you for joining. You're all probably pretty busy. So just move on to the next slide. So here are my disclosures. And then a disclosure with respect to the study. It's funded by the COVID-19 Immunity Task Force, and we'll review that when we get to a little bit more about the study. So today we're going to learn more about COVID-19 vaccines, how well they work in blood cancers, how well they work in the various types of blood cancers, and the outcomes of those with blood cancers who develop COVID-19. And we'll try and tackle the questions that have popped up when you registered. So the objectives of today's talk are we're going to look at the efficacy and the safety of COVID-19 vaccines for those with blood cancers. And we're going to take a closer look at those with lymphoma, those with myeloma, those with leukemia and myeloproliferative disorders, as well as a little bit at MDS. We'll look at the efficacy and safety in autologous stem cell transplant, where that's used in diseases like lymphoma and myeloma to wipe out the bone marrow and put in your own cells to lead to longer remissions, and in allotransplant, which is where someone else's cells are inserted in an attempt to eradicate an aggressive type of blood cancer such as leukemia. And we'll look a little bit at CAR T-cell therapy and how well COVID-19 vaccines work in that setting. After we've reviewed the evidence, we'll then move on and learn a bit more about the VIP study, which is a study that's ongoing at multiple sites across Canada. It's not opened at all of the anticipated sites just yet, but it's open in Ottawa, Kingston, Toronto and Montreal, and Edmonton, and then the other sites are in various stages of opening. And then we'll look at what's involved in the study and how you can participate if you're interested. And then we'll tackle questions that were posed at the time of registration. So first off, let's take a closer look at COVID-19. And so I know that everyone has likely heard lots about COVID-19 on the news. So SARS-CoV-2 is an RNA virus. And as you may have heard, RNA viruses are traditionally sloppy replicators. And because they're sloppy when they replicate, they're very prone to developing mutations. And so as a result, the transmissibility of an RNA virus can vary and can change and become more transmissible as time goes on because of errors in replication. The virulence can change, and I think we've certainly seen that with the various variants that have developed from alpha to delta, and escape mutations can develop. So the virus is constantly evolving due to the nature of the virus. And so let's take a closer look at the structure of COVID-19. So there's a couple of important components. There's the envelope that encases the virus, and so that's encoded by the E protein. There's the M protein, which is the viral membrane and determines the shape of the envelope. And then there are proteins that are more important in terms of determining immunity. So N, or the nucleocapside, binds to the RNA genome and is involved in viral assembly and budding. RBD refers to the receptor binding domain, and this can be used to look at antibodies that develop post-vaccination and post-infection. And the spike protein is the protein that attaches the virus to the host cell. So if you imagine you have, I guess, the human respiratory tract system cell, and then you have the virus with the spike protein, it attaches to the respiratory virus cell, and then that allows for viral entry into the respiratory tract. So the spike protein, a pretty important protein in COVID-19. And so why are we spending time talking about the various proteins? Is that antibodies to these proteins can then help us sort out whether after a vaccine you've developed immunity. So if we screen your blood and we see that there's an anti-N or anti-nucleocapside antibody develop, that is indicative of a past infection. If we screen your blood and we look for an anti-S and we detect an anti-S antibody, that could either be a past infection or vaccination, or if we detect an anti-RBD or receptor binding domain antibody, that can indicate vaccination. So based on these tests, we can determine whether you've had an infection or a vaccine. And so there are some commercial tests out there that are available like through private payment, where you can see if you've had a prior infection or whether your vaccine has led to a response. The challenge with some of those tests is that we don't know 100% how to interpret indeterminate responses. And so that's why the test isn't widely available at this time. And so just to move on to the next point. So what do we know about COVID-19 and those with blood cancers? How severe is it? What happens? What's our experience? But before we talk about that, I just wanted to make sure that we were all on the same page with respect to what the various blood cancers are. And so I know that many of you may be patients or caregivers, and you may know your particular blood cancer very well, but not know of some of the terminology of other blood cancers. So if we look at stem cells, so as you may have heard from your hematologist in the past, so the bone marrow is a factory where blood is made, and the earliest cell where blood is made is the hematopoietic or blood stem cell. And then it has the potential to then grow up into various lineages. So it can grow up into the myeloid lineage, and it can grow up into the lymphoid lineage. And so these are also very premature cells. And so if maturation stops there, that can lead to an acute leukemia, and that can grow like quite quickly. So if you have an arrest in maturation of the myeloid progenitor, you will develop acute myeloid leukemia. A related disorder is Myelodysplastic Syndrome, which has the propensity to develop into AML in the future. If your lymphoid progenitor arrests at this phase and doesn't grow up to be the next phase of the cell, you will develop acute lymphoblastic leukemia. Let's take a closer look at the myeloid lineage first. And so myeloid cells, so if they grow up from this phase, they can become a variety of different cells. So they can grow up to become megakaryocytes that then become platelets. They can grow up to be erythrocytes or red cells or hemoglobin that can also lead to disorders. Can grow up to be mast cells, myeloblasts, and the myeloblasts can differentiate into various types of white cells. So basophils, neutrophils, eosinophils, monocytes, and probably many of you are familiar with the neutrophils. And myeloid lineage blood cancers tend to be when there's too much of something in the blood. So if you have too much platelets or too many platelets, that leads to essential thrombocythemia. If you have too many red cells, that leads to polycythemia. And I think someone in the chat had a question about that. If you have too many mast cells, systemic mastocytosis, too many basophils, neutrophils, you get chronic myeloid leukemia. You can get chronic neutrophilic leukemia, chronic eosinophilic leukemia. These are fairly rare, and chronic myelomonocytic leukemia. And some of these disorders then in time can transform into myelofibrosis, which is a related myeloproliferative disorder characterized by pancytopenia and splenomegaly. MDS is when there's too little blood. And so why this is important is, and we'll talk about this in a few slides from now, is that those with a myeloid lineage heme or a blood cancer tend to form excellent responses to vaccination and tend to have very positive serology. What we've been finding is that those with lymphoid cancers tend to not mount as robust responses to vaccination. So I just wanted to make sure that we were all on the same page with respect to terminology. So if we then switch over to the lymphoid side of things, so lymphoid cells can then grow into natural killer cells and then small lymphocytes. Small lymphocytes can either be T cell or B cell. And then you can get, so if too many natural killer cells are developed, you can get a natural killer cell leukemia lymphoma. If too many T lymphocytes are developed, you can get a T cell lymphoma. And there's a large variety in terms of the multiple different types of T cell lymphomas out there. If you have B lymphocytes, they then grow up into plasma cells, circulating B cells, lymph, and can be in the lymph node. And so if you have too many circulating B cells, that can lead to CLL and some other types of indolent lymphomas. If you have too many cells and it depends a little bit in terms of where in the lymph node, but you can get Hodgkin's lymphoma and a variety types of non-Hodgkin's lymphoma, some of which are very aggressive, like Burkitt's lymphoma, and some that are moderately aggressive, like diffuse large B-cell lymphoma, and some that are indolent, like follicular lymphoma or marginal zone lymphoma. So there's a large variety. Plasma cell disorders, so if you have too many plasma cells, there's a variety of disorders that can develop, such as myeloma, amyloidosis, smoldering myeloma, MGUS. So this just brings us all on the same page with respect to the terminology of blood cancer. So just kind of a review as everyone's logging on. And so then when COVID-19 came about, everyone was quite concerned about how those with blood cancers would do, as those with blood cancers are highly immunosuppressed due to the nature of the cancer affecting the immune cells, and they're highly immunosuppressed from the therapies that they receive, whether they're transplants or chemotherapy. And so there were a variety of cohort or small studies across the world looking at if someone with blood cancer developed COVID-19, what are the risks and who is at the highest risk. So there was a systemic meta-analysis, and this was done in 2020 by one of my co-investigators, Abby Vidanthera, who's a lymphoma fellow here at Princess Margaret. And so this study looked at 38 studies that looked at 3,377 patients. And it looked at what was the risk of death in various groups. So adults had a higher risk of death than children. Adults who had blood cancers who developed COVID had a 34% risk of death versus 4% of children with blood cancers. Older adults had a higher risk of death of 47% compared to those who were younger. Treatment, whether you were on or off treatment, didn't have a significant impact. And those who were non-white versus those who were white had a higher risk of death. And I think that's been widely reported in the media. The thing to know about these studies, or these were the early studies done in 2020, and they largely looked at hospitalized patients. The other thing to note is that most patients who had a blood cancer and had COVID survived. So, we're looking at a large number of people surviving, and this study may be skewed towards those who had more severe disease. And so if we look at the risk of death from COVID based on the malignancy subtype, what this meta-analysis found was that those with bone marrow failure syndromes had higher risk of death, and those with leukemia had a higher risk of death if they contracted COVID-19, whereas those with like myelomas, lymphomas, CLL, myeloproliferative disorders had about a 30% risk of death. I think it'd be interesting to repeat the study, repeat this analysis now that there's more information out there, because perhaps the risk of death is a little lower than what's reported here. But I think the most important take-home point is that the majority of those with blood cancers who develop COVID-19 survive. And so what do we know about vaccine responses? So we know that those with COVID-19 and a blood cancer tend to have more severe disease and are at higher risk. How well do vaccines work in those with blood cancers? And so there have been a lot of different studies looking at this. But first, before we go through that in a bit more detail, let's look at what sort of diagnostic tests are out there. And this may have been addressed and covered in some other webinars on COVID-19 through the Leukemia and Lymphoma Society in the past. So the diagnostic tests, though, like everyone is probably pretty familiar with the nasopharyngeal swab, that swabs the very back of the nose and the pharynx. And what it's looking for are tiny bits of viral RNA at the end of the swab. That swab then goes to the lab. And what happens is that it goes through a process called polymerase chain reaction, where multiple copies are replicated so that it's at a level that we can detect, and then we can detect if it's positive or negative. This detects people who are acutely infected. It amplifies a very small amount of genetic material in a sample, and it's the gold standard for identification. You may have also heard of rapid antigen testing. This has been in the news pretty recently as a way of a screening tool. And what the antigen test does is that it identifies little fragments of COVID-19, and it can detect people who are acutely infected. The challenge is, depending on the test, there can be high false negative rates. So you may miss a diagnosis of COVID-19 more so with the rapid antigen test than the nasal pharyngeal swab. So that's diagnostic tests, and they're also looking at RT-PCR and saliva as well. But how do you detect if you've had COVID-19? So we talked a little bit about this on one of the first slides where we looked at the picture of the virus. So we want to detect the presence of the antibody. And so, as many of you may know, an antibody is a protein that's protected in response to a foreign substance. And depending on what type of antibody is generated, that can tell you if it's a past infection or vaccination. So if you have an anti-N to the nucleocapsid, that indicates past infection, whereas if you detect an anti-S or anti-RBD, that can indicate either infection or vaccination. And so then putting all of that information together, you can sort out if the positive serology is from a past infection or vaccination. There are more tests that are not available commercially and are just research at this point, and they're quite involved and expensive, so they're not available to the general public, and they're also quite difficult for us to get as well. So neutralizing antibodies are a functional correlate of immunity, and that determines how well the antibody works, and it may predict protection from infection. And cellular immunity, so the COVID-19 virus, it induces a T cell response that then induces neutralizing antibodies, and then having strong neutralizing antibodies leads to a durable antibody response. So this is one of the first responses, and we are looking at neutralizing antibodies and cellular immunity in a subset of patients in our study. So if you want to get tested, it's available commercially. And cellular immunity is not routinely done in clinical care or accessible at this point in time. So you could get tests. So LifeLabs and DynaCare both have tests that are available. The DynaCare will look for the anti-spike antibody, which is can be indicative of vaccination. I believe the LifeLab test just looks at the anti-nucleocapsid antibody and not the anti-spike antibody, although that might change in time. And so as part of our study, which we'll talk about in a bit, is we test both anti-N and anti-S, and if you participate, you can log in and look at your anti-S results. And because we have lots of patients getting tested, it often takes several months for you to get the results, though, so it's not available in real time. Other things to note, so this study looked at how well people responded. So now that we know what the various tests are and how to access them, how well did people respond? So this study looked at 67 patients who received Pfizer or Moderna, and 31 of them did not respond. And what they found is that older patients tended not to respond. Those with CLL were less likely to develop antibodies. And it was particularly pronounced among those with CLL. And so what this pointed to is that it's pretty important to ensure that those around you are vaccinated to help prevent COVID-19 amongst those with blood cancers, and that things like good hand washing, masks are important to continue. A meta-analysis that hasn't yet been published, that one of our co-investigators is an author on, looked at 17 studies involving 2,834 patients and looked at how well the various subtypes responded to vaccination. And what they found were that the lowest responses were in those with CLL, and those with myeloid malignancy tended to have the best responses. And T-cell responses seem to occur earlier. So this study here looked at 151 patients with cancer, included solid tumors as well as those with heme malignancies and some healthy controls. And this looked at the Pfizer vaccine, and they found that 75% had a T-cell response after the booster, but if they didn't, and this was the second dose booster, so not the third dose booster. So if you didn't have the booster, you tended not to have as robust a response. So this study demonstrated that it's very important that those with blood cancers, complete the 2-course series for 2-course vaccine. And then this study looked at those had a large cohort of patients with blood cancers. It had 131 patients who received an mRNA vaccine, so Pfizer and Moderna. And they found that those that completed vaccines had better seroconversion rates. This cohort was largely those with solid tumors. But when they looked at the heme malignancy cohort after 2 doses, there was a lower rate of seroconversion. And risk factors for those who develop poor responses are those with blood cancers, those on chemo, and those who are receiving a monoclonal antibody such as rituximab. Quick look here. Okay, so I'll just make sure that we look at these questions in the chat and the Q&A. I'll take a look at those at the end, I suppose. Or Sonia, who's moderating the chat, we'll make sure that we address some of those questions. So what about the booster? So I know that there is a 3rd dose available to some individuals with blood cancers. Currently, the guidelines may largely are the same throughout Canada. And I think they've just recently been updated. So the Ontario guidelines are those who are currently getting chemotherapy would qualify for the booster, or who are within 6 months of getting chemotherapy would qualify for the booster. Those who've had an allo transplant would qualify for the booster if they're within 3 years. Those with an auto transplant within the last 2 years would qualify for a booster. Those who've had CAR T therapy, and those who were vaccinated while getting the first 2 doses on rituximab or within 12 months of receiving rituximab or obinutuzumab, and then various other high-risk settings. And where did this data for the booster come from? So Dr. Kumar, who's one of the oncology infectious diseases doctors at the University Health Network, and her team did a study looking at solid organ transplants. So those who've received, kidney transplant, liver transplant, heart transplant, and they're a similar population to those with blood cancers because they're very immunosuppressed. They're often on long-term steroids, and so are similar in that way. And so she did a study of 120 patients. Half received a third dose, half did not. They received the third dose 2 months post their second dose of Moderna. And they found that those who received a third dose had a marked boost in their immunity compared to those who just received 2 doses. And so as soon as the study was published, those who had a solid organ transplant immediately gained access to a booster. And then as soon as the study was published, like within weeks, the data was extrapolated to other immunocompromised populations, such as those with blood cancers. And so at the end of August to early September, there was this flurry of activity in terms of now there was data to show that there's evidence for a booster and what populations would benefit best from a booster. So that's a little bit about the booster. So if you're not sure if you qualify for a booster, best to check with your physician, and then your physician may have specific recommendations in terms of the timing of the booster, depending on where you are in on treatment. And they may also have specific recommendations based on where you are in treatment and where you live. So if you're in a very endemic area, it might be better for you to get a little boost. Whereas if you had gotten the booster and maybe 6 months from now, you'd get a bigger boost, but you're at risk. You're potentially at risk now, so they may personalize that decision for you. So best to connect with your hematologist about that. So let's take a closer look at the various diseases. And so let's look at lymphoma. So there's not a lot known about immunogenicity of vaccines in those with heme malignancies, and the best studies that were done before COVID-19 looked at how well those with lymphoma developed antibodies to the pandemic influenza vaccine, which was back in 2009, H1N1. So there were studies looking at how well did those with lymphoma develop antibodies to H1N1 vaccine. And those who were never treated seemed to mount excellent responses. Those who were on non-CD20 antibodies, so non-rituximab, not obinutuzumab. And if you're not sure if you're on an anti-CD20 antibody, best to check with your doc. And so if you're on active treatment, but not on B-cell depleting treatment, you know, there's a range of responses there. But if you got the vaccine a month after your last treatment dose, you had excellent responses. So from this, people have come to the conclusion that, you know, a month after your last treatment would be a good time to be vaccinated, as you're more likely to develop a response. If you have had exposure to like rituximab or obinutuzumab within 3 months from the last dose, really not likely to develop a response. 3 to 6 months, a little more likely. 6 months plus, more likely to develop a response. And this also makes sense with the guidelines that we saw here, that if you were vaccinated within the first 12 months of therapy with rituximab, that it may be a good idea to get a booster after the 12-month mark, because you're more likely to develop a response. Rituximab depletes or decreases your B cells, and then your B cells help make antibodies. So if you've so this is an excellent treatment in lymphoma. It helps lead to many lymphomas being curable as a result of the addition of this, but it decreases your B cells, and then as a result, you can't mount an antibody response. So for this group, certainly very important for those around you to be vaccinated and to adhere to public health measures. So that's lymphoma in a nutshell. And there have been more studies looking at lymphoma and COVID-19 vaccinations as well that have shown similar results. And so what do we know about COVID-19 and myeloma? So what do we know about myeloma in general? So in myeloma in general, there is a 7 to 10% risk of being more at risk of bacterial and viral infections, just to the nature of myeloma. It also affects your plasma cells, which help create antibodies. So if they're impaired, you're likely not to develop an antibody response. And so in the past, there's been not great data on how well vaccines work in those with myeloma, and how well they work with those who've received various types of treatment. So those who are on IMiDs like lenalidomide, pomalidomide, not really well known in terms of how well the vaccines work. And those on proteasome inhibitor, there are like very small studies. So this is certainly an area that just needs more investigation. And that's one of the purposes of our study. So there have been studies looking now at vaccination and myeloma. And so this was a study in the UK that looked at 93 patients. And this looks at their response after one dose. And the dose was either Pfizer or AstraZeneca, because that was what was being given at the time of this study. And it was in the UK. And so what they found is that there was really no difference in terms of who developed a response based on the agent that was used. So whether it was an mRNA vaccine or a viral vector vaccine, it didn't really make a difference in terms of who responded and who didn't respond. What did seem to make a difference was if you had disease that was progressive or stable, you were more likely to not respond. If you're on treatment, more likely to not respond. And a similar study was done in Germany, and this looked at 82 patients with a variety of plasma cell dyscrasias, so myeloma, smoldering myeloma, amyloidosis, and looked at how well antibody responses were developed. And what they found were, like the key things they found were those who were getting anti-CD38 antibodies, like daratumumab, isatuximab, had poorer antibody responses. Those who had low CD19 B lymphocytes in their blood had low responses. The type of vaccine made no difference, and those who were older had poorer responses. So that's myeloma in a nutshell. So what do we know about leukemia and myeloproliferative disorder? So some of those pooled analyses that we saw earlier showed that there were excellent responses in leukemia. And then in CML, there was a trial, I think I'm just missing the slide here, that looked at 16 patients in CML who were vaccinated, and 88% had developed a response after one dose of an mRNA vaccine, and 93% had developed a T-cell response. So those with CML tend to do very well, and they don't seem to have impaired responses. And from some of the meta-analyses that we've looked at, it seems to be similar in leukemia. So this is an area that needs further study as well. And I saw in the chat there was a question about what about ruxolitinib? So that's an area that hasn't been well examined, and so we hope that our study will address that as well. And so what do we know about auto and allo transplant? So there was a study that looked at 50 patients that had undergone an auto and allo transplant, and what they found was that there was impaired production of the antibody in those with allo transplants, but not in those with auto. Those who had rituximab in the past had impaired antibody responses. Older patients had poor responses, those receiving immunosuppressive therapy, and those with low CD19 counts had low responses. So let's just take a quick peek. So for some of these questions, okay, I might, so we'll try and answer some of these at the end, I suppose. Okay, so, and what we might do is that if we don't get to everyone's questions, maybe I can chat with Sonia and we can sort out a way of answering them on the website. A closer look at the VIP study. So this is the study that I wanted to talk to you about today that looks at, it's a way of measuring your immune responses in those with blood cancers. And this is a Canada-wide study at multiple sites in Ontario, Quebec, Nova Scotia, Manitoba, Saskatchewan, Alberta, BC. We have 4 main hub sites, and then we have smaller sites across the country. So the big sites are Ottawa. So our lead investigators for the study are Adrienne Buchan, who's an oncology infectious diseases doc in Ottawa. Myself, I'm a myeloma lymphoma cell therapy auto transplant doc at UHN. Abby Vijanthera, who's a lymphoma doc or lymphoma fellow, soon to be a lymphoma doc at UHN. Peng Wang, who's a leukemia doc in Edmonton, and Michael Seabag, who's a myeloma doc, cell therapy doc and auto transplant doc in Montreal. And so with this study, you can find out how your body responds to COVID-19 by participating. The best way to participate is to go to our website. This email is only for UHN patients, so those who are in the University Health Network in Toronto, but there will be other contact information on the website if you are not a Princess Margaret patient. This is a flyer that was just for our institution, but the other sites have similar flyers with their correct email address. So just make sure that you email the correct coordinator and just check out the website. So what is our study looking at? So it looks at 1,404, we hope to recruit 1,400 patients with multiple subgroups based on therapy and diagnosis, pre and post booster immunity testing. And what we're looking at are 5 time points where we assess how long the response lasts for. We're only looking at cellular immunity in a small subset of patients, in part due to cost and logistics. We're only looking at that in 200 patients, and we're looking at that in patients that we predict will likely not have good responses. So some of our subgroups are, those on rituximab, CLL patients, those on anti-CD38 antibodies, and then we're going to track if any infections happen after vaccine and what happened. What's the benefit to you in participating? So you can access your results on a web portal. So you can log into our website and look at your results on a web portal, but there may be a time lag in terms of receiving the results. So the study was looking at recruiting anyone who's an adult with a blood cancer who either intends to receive a vaccine or has received, anywhere from any number of doses of a vaccine. And the only people that are excluded are if you can't get the vaccine or can't consent. We're also not recruiting CML patients on treatment, and likely not recruiting those. I think I quickly saw a question on Hydrea because we don't anticipate an impaired response with Hydrea. We're not focusing on that. And so our blood, so this project looks at those with lymphoma, myeloma, acute leukemia, myeloid cancers, allo, auto, and cell therapy. And these are the subgroups that we are going to analyze and recruit based on. So these are largely based on past treatment. These are based on types of disease. And the transplants and cell therapy are based on time from therapy. And what we're primarily looking at are the humoral response rate, safety, secondary objectives. We're going to compare the response rates that we see to age matched control. So there is a kind of sister study that's ongoing in Ottawa called Stop the Spread Ottawa that looked at those without blood cancers or solid organ transplant or immunosuppressed in any way, and their responses post-vaccine, and we'll compare that to those with blood cancers and see if there's a difference and in which groups there's a difference. And then we're going to look at the durability of response over time. So we'll look at the durability over 5 time points, and then there's an exploratory study of about 200 patients where they will get more extensive testing done. But the only results that are going to be available to see when you log in are just the antibody results. So you won't get the results back of the cellular assays. And then we're also going to look at the differences between mRNA and non-mRNA vaccines. So there's multiple other exploratory objectives of this study. And the sample size broken up by disease site. And so if you're interested, what's involved? So basically, what's involved is there'll be a baseline questionnaire that you can do on the website. There's a side effects questionnaire if you're receiving a vaccine. There's a follow-up questionnaire at the various time points, and then you need to provide us with a dried blood spot. And so this is something that can actually be done at home. We would mail you out a kit, and what you would do is take a bit of blood, kind of like a diabetic might check their blood with a glucometer, and we would show you how to do that. There's also a video on YouTube that our team has created, or the Stop the Spread team has created, that our team is using, where it shows you how to get a blood spot and how to put it on the card, and we would get 5 little spots of blood from you. Really important to saturate the entire spot. Otherwise, if it's kind of half filled, you may not get a result. And to let the card dry for a couple of hours before you mail it back to us. Otherwise, that may impact the results or lead to incomplete results. And this is what the kit looks like. And it might look a little bit overwhelming, but our coordinators will talk you through it over the phone. And this is what our website looks like. And so that's the website up here. And so on this website, you can read a bit more about the study. You can see how you can help out with vaccine research, check in if you're a participant, you can enroll through the website, and this tells us how many people have enrolled. This number may not be entirely accurate because anytime our webmaster checks the site, it kind of generates a participant. So don't ever be alarmed that it says, there's 999 participants and 1,000 are needed. A number of those may not be there could be test cases from the webmaster. So if it ever gets to 999, still enroll, and then we'll see. Great. And then let's say you enrolled, you would get a passcode, and then you'd have to sign a consent, and then you'd be connected with the lead coordinator would connect with you. And then once the consenting is done, you've connected with the lead coordinator, you would get a unique participant number, and they would tell you what steps are needed next. And this is where, and we have a nice link to the dried blood spot collection video, so you can check it out before you collect your first sample. And then our study staff will connect with you at various time points just to make sure that we connect with you before the next time point. So we're going to try and get your blood about 5 times over the span of 18 months. And so then there's a questionnaire that you will fill out on the website. And all of the COVID-19 immunity task force funded studies have very similar questionnaires that were designed by the task force, and then we added questions that were relevant to us as well. And then if you're not comfortable, using the website, our coordinators can go through the questions with you. So that is just a little bit about the study. So if you're interested, definitely check out the website. We'd be very grateful for anyone who's interested to participate. And I think now we have some time for questions. So let's take a peek at the questions. So the first, and these questions were the ones that were kind of selected based on, I guess, the number of people who asked similar questions when you first registered. So question one is, how long after a stem cell transplant can you safely get the COVID-19 vaccine? So this depends a little bit in terms of which type of stem cell transplant you've received. The guidelines from the American Society of Transplant are that after 6 months post allogeneic transplant, you can get the COVID-19 vaccine. 3 to 6 months post CAR T, you can get the COVID-19 vaccine. About 3 months post auto, you can get the COVID-19 vaccine. There may be some very specific like personalized decision making that needs to be done around vaccine post allo, CAR T, and auto, particular to you. So always best to speak to your hematologist. For example, if you've received an allo and are on graft versus host disease treatment, your allo doc might have some suggestions in terms of when you can get vaccinated, because it might be if you're on very high doses of immunosuppressive therapy that the vaccine may not work very well. So how long after chemotherapy can I safely get the COVID-19 vaccine? So this is an excellent question. And again, it depends on what type of chemotherapy you've received. So I think I very briefly saw a question in the chat about hydria, so there's no restrictions with respect to that. Whereas when we looked at some of the studies earlier, the best time post chemotherapy was about a month, and that was in the non-CD20 antibody receiving chemotherapies. If it's post anti-CD20 or like rituximab or pertuzumab chemotherapy, the best time to receive the vaccine for it to work would be 6 to 9 months later. That being said, sometimes if there's a lot of cases or you're at high risk, let's say you're a frontline worker or you work in a nursing home, like you may have a personalized discussion with your doc about maybe getting the vaccine earlier just to get a little benefit, rather than waiting 6 to 9 months without being vaccinated. So this is always a personalized decision. We also generally recommend that like steroids like dexamethasone should be held 7 to 14 days after the vaccine, but there may be some who can't safely hold their steroids because it may then lead to their blood cancer growing quite quickly. So there's always caveats to this. So always best to discuss your particular circumstance with your hematologist. And then in terms of, I guess, the word safely, so it is, very safe. And I think that comes up in another question. So how long after remission am I not considered immunocompromised? Depends on the specific type of blood cancer that you have. So, post-auto, I would say 3 to 6 months. Myeloma, you may constantly be immunosuppressed because often with myeloma, you're constantly on immunosuppressive therapy, whether it's like lenalidomide until the disease comes back. And you may have hypogammaglobulinemia as a result of the myeloma, which can lead you constantly immunosuppressed. Rituximab, as we talked about, 6 to 9 months post. So it depends a bit on the condition and the therapies that you may or may not be on. So how does this apply to chronic blood cancers, CLL, CML, follicular lymphoma? So we talked a little bit about this during some of the slides before the VIP study. So those with CML tend to have really robust responses, to vaccination. So that's good to see. CLL, as we talked about, even with vaccination, can have poor responses to vaccination. And also it may depend a bit on the treatments that you're getting for CLL. So you'd be at risk with CLL. Often CLL has hypogammaglobulinemia as well. Follicular lymphoma, it depends on whether you're treated or not. So if you have follicular lymphoma on observation or maybe just treated with radiation, I would expect that you would mount a good antibody response. But if you've had follicular lymphoma or on Ritux maintenance, you may not mount as robust a response. So again, it's a diverse type of or range of blood cancer, so always check with your doc with respect to personalized information. Will the booster, so the third dose, increase my level of protection at what level? So hard to tell you exactly to what level, but based on the data from the solid organ transplant, the third dose boosted protection up in those who received it, and is recommended for select populations of those with blood cancers, so those on treatment, those who just completed treatment, certain types of treatment, allo, auto, CAR T patients as well. So how safe is the vaccine for immunocompromised individuals and those with blood cancers, the mRNA vaccine? So there haven't been increased reports of toxicity compared to the general population. So both the viral vector vaccines and mRNA vaccines are safe and highly recommended. So next, so how does the vaccine work with immunotherapy protocol? Do immunotherapy drugs provide any protection against COVID-19? So unfortunately, no. So immunotherapy drugs may decrease your protection and how well the vaccine may work. It would be recommended, depending on, I guess, the type of immunotherapy that we're talking about, it generally would be recommended to consider the third booster dose. How can we get tested to see if we've achieved immunity after the vaccine? So talk to your hematologist, but they may be able to write you out a requisition to like Dynacare, so you can get a sense of what your immunity is. But the challenge is that we don't know enough to interpret the gray zone results, and we've been seeing quite a bit of that. And so we won't be able to tell you definitively whether that provides you with enough immunity. So I generally only recommend it to my patients if it's going to change what they do. So if it, if they're like very concerned about sending their kids to school and they want to get a sense of what their immunity might be, it might be worth it in that scenario. But I think it's a personal decision based on risk or your tolerance for risk. Are there any treatment drugs that affect the efficacy? So certainly the anti-CD20 antibodies like rituximab and obinutuzumab. In myeloma, the anti-CD38 antibodies like daratumumab and isatuximab, steroids. So there are certainly drugs that affect the efficacy. If you're cured, is that different than being on treatment? And it looks like in some of the studies that we reviewed, that you may be more likely to mount a response to vaccine, whereas if you have progressive disease, you may be less likely to mount a response to a vaccine. An American, Dr. Ryan Cole, pathologist in Idaho, says vaccines will cause cancer. What are your thoughts on this? So my thoughts that there aren't any evidence indicating that vaccines can cause cancer. Vaccines are safe and very highly recommended, particularly in those with blood cancers. Is there any evidence that one or more of the vaccines work best for those with blood cancers? We've some of the studies that we looked at AstraZeneca versus Pfizer, Pfizer and Moderna, and there wasn't any evidence that one vaccine worked better than another for those with blood cancers. The more predictive things were often things that you can't change, like if you're older, the type of treatment that you received, like where you are in terms of treatment are more predictive in terms of whether the vaccine will work or not. Great. So I'm just going to pass it over to Sonia.
So I'm going to take over, Dr. Bella, and I would like to thank you very much for sharing your expertise and your insights, as well as answering all of those questions. I just wanted to mention again that we received a very high volume of questions before the webcast, and As you saw in the question and answer section, as well as the chat section, there was a flurry of activity. So we won't be able to answer all of the questions at this time. However, we do have a list of the questions and we'll try our best to get answers back to everybody. And I would like to remind you, as you can see on the slide that's on the screen right now, that if you require any further guidance or have any further questions, please don't hesitate to reach out to and contact the community services manager in your area. We would be very happy to get you that information. Dr. Bella, I do have one question for you though. Can someone participate in the study if they're not being treated at one of the listed centers?
So right now, no. So you would need to be treated at one of the listed centers in order to participate. So right now it's only open in Ottawa, Princess Margaret, Montreal, and Edmonton and Kingston, but there are multiple other sites that are going to come online within the next few months. So I would just keep checking the website to determine whether the site that you're currently treated would be included in the study. And if you're not sure, you can email the overall coordinator and then they can answer that question. So yeah, I can see, I'm just quickly scrolling through some of the questions and I can see that was a key question. So if, let's say if you're in Toronto, if you're treated at Toronto East General Hospital, you wouldn't qualify to be part of the study, unfortunately. So I know that's disappointing for those that are like very eager to be involved. But right now it's only for patients who are currently patients at the sites that are open and or that we're planning on opening.
Perfect. Thank you for that answer. So could we go to the next slide? So just before we sign off, I'd like to announce that in November of this year, we will be hosting a week-long Living Well with Blood Cancer conference. You can hear some experts speak on topics such as nutrition, sleeping well with blood cancers, blood cancer and sexuality, and much more. So could you please visit bloodcancers-conference.ca for more information. Next slide. And I would like to remind everybody that we're always here to help you. Do not hesitate to contact the LLSC if you need more information or support. You can reach us by emailing info@bloodcancers.ca or calling toll free at 1-833-222-4884. Also, please make sure to check our website, bloodcancers.ca, to learn about upcoming webcasts and podcasts and other special events. Please note that a short survey will be sent to all participants after the webcast, and we would greatly appreciate you taking a moment to fill it in, as it will help us offer you the most valuable information in the near future. Thank you for joining us. Have a wonderful night, and please stay safe.
Thank you.